please help me welcome our afternoon keynote speaker, Ms. Jennifer LaBay. Jennifer.
Well, thank you. I've never been a keynote before. I feel so fancy. So thank you very much. I work for AAPACN, and if you're familiar with our old name, ANAC, a lot of people don't realize we changed our name a couple of years back. But we are staying up on all of this stuff so we can bring it to you all. Now, this slide deck's a little longer, so I'm going to have to get right into things because I am tooting the horn of the MDS coordinators to make sure that you all get the support that you need and make sure that your DNSs and your administrators and everybody understands, like, if you don't have these things going on in your facility, you're going to lose out. So let's go right into it and talk about all of these things. Responsibilities of the nurse assessment coordinator, the NAC is what I refer to them as, the consequences of what happens if we have a late or missed NAC task, and what can we do to help mitigate these things and prevent these things from happening, and what can we do to maybe assign some of these things to maybe some other folks. So a lot of this came about because of, and we have lots of acronyms for you to reference. We do love our acronyms in long-term care, don't we? So what does the NAC do? What does that MDS coordinator do? Well, let's discuss this. A lot of folks don't understand necessarily what it is the nurse assessment coordinator does or what they're responsible for, whether it's the frontline staff or, hopefully not, our administrators or DNSs. But we need to understand that this role is imperative not only to care, which is first and foremost the whole reason why the MDS exists, is because we need to provide proper care to the residents. Years ago, facilities didn't do very well in that, so the government decided, we're going to standardize this to make sure that you're looking at it the same way. And then they applied all of these other things to it. So payment, quality measurement, public reporting, all of these things are majorly, the majority of them, I can't spit the words out, related to the MDS. And we have some claims-based things, and now we have to report to NHSN and all of those, but the majority of the care, the payment, the quality measures, the public reporting is coming from information on the MDS. And if we don't have that information correct, first and foremost, we're not going to have a correct care plan. We're not going to provide good quality of care to our resident, and then we're going to be leaving money on the table. I hate that phrase, but that's exactly what it is. We're going to not accurately reflect the care and services that we're providing when it comes to public reporting. Our star rating is going to change. Our quality measures are not going to be accurate. Maybe they look really good. Maybe they're not really accurate. We need to make sure that this information is accurate. And the person who is in charge of this in your facility is that nurse assessment coordinator. They are the ones who are digging in, understanding what's in that 1,600-page manual, and what needs to be coded when and that's just for the REI. That's not looking at anything else. That's not looking at the State Operations Manual Appendix PP. That's not looking at Chapter 8 of the Medicare Benefit Policy Manual, looking at the Claims Processing Manual, all of these things that are incorporated, or all of the other manuals that go along with it, the quality measures, the 5-star technical specs, the SNF QRP, all of this, the MDS coordinator, the NAC, has to have an understanding of. And they're driving the train. I was always accused of being, I should be a union steward for MDS coordinators. Huzzah, yes, because we are the ones that are kind of driving your SNF train here. So let's look, we're gonna take this from pre-admission all the way through discharge. So pre-admission, what are some of the things that the NACs are doing? We're reviewing the incoming residents for eligibility, potentially. Maybe we have business office doing it, maybe we have admissions doing it, maybe we have the NAC doing it. We have to make sure that they've had a qualifying hospital stay. We have to make sure, because that whole thing, you all know that went away, right? That waiver, the waiver went away. So now we have to have this qualifying hospital stay, pandemic be done according to the government. So they have to have a qualifying hospital stay in place. There have to be days available. Somebody has to understand what the Medicare rules are. Then we have to determine on admission, do they meet skilled criteria? Well, who is making that determination? Do we know what the skilled criteria is? Do we know where this skilled criteria comes from? Do we know what the administrative presumption of coverage is? These are all of the things that your nurse assessment coordinator may have in their back pocket of knowledge, and if they're being pulled to the floor because we're in a staffing shortage, which the residents need to be taken care of. I understand that 100%. But you all as operators and leadership need to understand, well, somebody else needs to pick up these things then, because this is all of the stuff that has to get done and a lot of time falls into the NAC's lap. Beneficiary notice initiative. If the resident is coming in and is not covered under Medicare, we need to give a notice to tell them your stay is not covered under Medicare. Or if they qualify technically for Medicare, but they don't meet the skilled coverage requirements, we are required to give them a notice on admission to say they don't meet the criteria. And if we don't, we have financial penalties associated with that. So we need to review those incoming residents. If the qualifying hospital stay is miscalculated, your entire stay is going to be provider liable. That means you can't bill Medicare, you can't bill Medicaid, you can't bill managed care, you can't bill the resident privately. You just gave free care because they didn't meet the technical requirements. We can't just admit them from home anymore. With that DR disaster code from COVID, that went away back in May. So they have to have that 3-day qualifying hospital stay. If you have folks in your facility have only been working in SNFs since COVID has been in place, they may not know this. Oh, what do you mean we can't just admit them from home anymore? That was May 12th that this ended. So we need to make sure that we understand what is a 3-day qualifying hospital stay, who's in charge of checking to make sure that that was met, because if that's not met, you're done. Technical, you don't even have to do anything else. Any reviewer is just going to say denied, and that is not something you can appeal. So we need to be looking in the HET system, formerly known as the Common Working File. This is going to be the claims that are submitted into Medicare are going to create a database for who has days available, how many days have they used, do they have qualifying hospital stays, when was the last time they were billed. But this is only as good as the last entity who sent in a claim. Now, if you have a facility who has not sent in a claim timely, I was in a situation where we had a new owner and we didn't have a provider number yet, so we couldn't bill. And that would be a situation where maybe we weren't billing timely, so then this is not going to be accurate. So what do we need to do to make sure that we have the right information? We don't want to be provider liable. That is, administrators, you hear the word provider liable and you want to cringe and beat someone up, because that's not what you want. You don't want to be given free care. Yes, it would be lovely if we could, but that's not how it works. So when a facility fails to follow all of the rules and regulations of Medicare, as I said, we can't bill Medicare. We can't bill anyone else. We can't bill them privately. And the facility is now responsible for paying for these services. These could be very expensive services. If they were receiving lots of therapy, if they were receiving lots of medications, if they were receiving lots of services, we can't just parse that out to other entities and bill individually. No, this is a consolidated claim. We are responsible ultimately for making sure that we are following all of the rules of Medicare, and now we can't bill anyone, and now we're provider liable, and that is going to be something that's going to be impacting your bottom line for sure. There is also a situation where a facility, if we're not being timely or other issues, where we could get paid at the default rate. So this is going to refer to the lowest possible daily rate calculated under Medicare. This is going to be coded as a default code of ZZZZZ. Under the old RUG system, it was the AAA, so the ZZZZZ. This is going to represent the equivalent of the lowest paying PDPM groups. So PDPM is made up of 5 case mix components: PT, OT, speech, nursing, non-therapy, ancillary. And these are the different component scores that it would be equal to paying under. It's not a lot at all, but it's better than provider liable. So provider liable means no money can be collected. Missed MDS, for example. Oops, they've discharged, today's day 10, we never set an assessment. You can't go back in time. Unfortunately, sure, you could go back into the computer and put it in. It's illegal to do that because you have to set your assessment reference date on or before day 8 of that Medicare stay. And if you don't set your assessment reference date on an MDS form in the MDS software by midnight, 11:59 p.m. on day 8, then you are going to be a late assessment. Now, if the resident has already been discharged from your facility or taken off of Medicare coverage before you realize, whoops, I never did that, you are going to be provider liable. You can't go in and do an MDS and say, oops, I forgot that. Well, this person had this date written on their calendar, so the assessment reference date was set. No, it has to be set in an MDS form, the actual paper form, or in the MDS software, no later than that date. So these are some of these tricky things that folks don't realize we need to be on top of. So it's not so much when you're here out at a conference or doing whatever, who's doing the MDSs? It's who's setting your ARDs. That's what you need to be worried about. Who is setting the assessment reference date for that person in the MDS software, so I am not going to end up either with a default rate or that provider liable. So with a completely missed assessment, you can't go back in time. You cannot set the assessment reference date. This is still the same page number, draft manual versus our current manual. Chapter 6 of your REI user's manual is speaking to Medicare and PDPM. So there are 6 exceptions to this missed item. The billers are going to put the occurrence span of 77 on the claim with the dates of provider liability, and we're all going to be cringing when this happens. The default rate, that ZZZZZ, is the lowest Medicare rate that can be collected. So if you have a late assessment, so today is day 9, you realize, oops, I forgot to set that ARD, you're going to set the ARD for today, day 9, you're going to be 1 day late, and the first day of your payment period is going to get paid at that default rate. But if today is day 10 and they discharged on day 9, you can't go back in time. That's a missed assessment. You're now provider liable. You can't do anything about that. Sure, you could be fraudulent, but we don't want to do that. That's not good. That's the big bad F word. So one thing you do have to be careful of is your softwares. Sometimes your softwares will show up as a default rate. So if you're doing your monthly triple check, you're putting your claims together for Medicare, and you see this default rate on your claim. What's going on with this? Why do we have this default rate? And the software is just going to show that. Oops, we forgot to do the assessment. Just because your software is showing that it's a default rate doesn't mean you can bill at the default rate. You need to analyze that. So if you see the situation where, oops, we've got the default rate for Miss LaBay, she discharged on day 9, we're now discovering this on day 14, and we can't go back in time. The software is going to say the ZZZZZ because we need something missing, but we can't bill that. We have to understand what the rules of Medicare are and the claims processing manual. We have to understand that. We can't just say, oh, well, we can just bill this because the EHR has us at the ZZZZZ. Nope, we have to do it the proper way, provider liable, and things would have to be manually changed if you have an integrated system. So just be mindful of that. Just because your software says that you'll get paid at the default rate doesn't mean you're supposed to get paid at the default rate. You have to understand what these rules are. So how do we manage this? We want to assign the review of eligibility maybe to admissions if we aren't already doing that, or the billing staff that is competent of Medicare regulations. We want to make sure that staff are cross-trained. So whoever is in charge of doing that is taking a vacation. You guys are allowed to take vacations. You know this, right? Yeah? Okay. Just checking, because I know a lot of times I can't leave. I'm going to have more work before I leave, more week after. You can. It's allowed. You need to. Mental health, weren't we just discussing? Mental health is very important. Think of it as what do they tell you at the airplane? When the oxygen mask comes down, you put it on yourself first. Then you put it on whoever you're with. You need to do that. You have to take care of yourself. So you are allowed to take time off. Sidebar. So we need to make sure that whoever staff is going to be taking on our work when we are on vacation or working the floor or home with COVID, whatever it is we've got, that they understand what a qualifying hospital stay is, how to count that, when does it start, the count. Oh, well, they discharged from us at 10 p.m., so the count starts there. Nope, they were not admitted until 12:30 a.m. the next day. Your count doesn't start until the next day. So you have to know these things. Where to look in the HET system. How do I find it? Where do I access it? What the heck is it? Do we understand these things? And then we have to ask further questions because the HET system isn't always correct, depending on when we last billed. Interview that beneficiary or responsible party about the previous SNF stays in case that HET system is not accurate. Where have you been? Where have you been? What have you been doing? Who have you been doing it with? We need to understand those things so we can make sure we have to do our due diligence. As a facility who is providing Medicare services, we have to know all of the rules of Medicare. We have to follow all of the rules of Medicare. So we need to not only look at what Medicare has in place, but ask the questions. Were you somewhere else? Did you have something else? And then pick up the phone. I was not afraid to pick up the phone and say, hey, I understand you had Mrs. So-and-so, and can you tell me how many days you billed Medicare? Or haven't you billed yet? Or, were they, even calling the hospital, were they an inpatient? What was their actual date of admission? Don't be shy. So this is, I got ahead of myself, just caution when your software is telling you the ZZZZZ. Yeah, we have to make sure that it's accurately reflecting what you need to do. So staff familiar with the rules of Medicare and the REI User's Manual should review all claims to ensure accurate billing and confirm the HIPS codes prior to billing. Who is doing a triple check in your building every month? Do we know what a triple check is? I only see a few hands and I'm a little scared. I'm a lot scared. No, we need to make sure, maybe you don't call it a triple check. Maybe it's a claim something, a Medicare, not necessarily a Medicare meeting, because we're not talking about their skilled services. We're talking about every month looking at the claim clinically. We're comparing what was on the MDS to what is on the claim, what is in the physical therapy to what is on the claim, what are the ICD-10 codes to what is on the claim, the admission date, does that jive up? Do we have all of the right things? If you're not doing that in your building, you might be doing yourself a bit of a disservice. So think about that. I have cards. I can help, guide you through that process. But that's definitely something that you want to do. Somebody needs to be involved in making sure that this is correct and that we are following the rules of Medicare. Just because something can slip through in the electronic bill and get paid does not mean we're supposed to. Medicare is not that checks and balanced like credit card companies are, where they'll shut you off because you went to Mexico and you forgot to tell them the card that you were going to Mexico and they shut you off. Medicare's not that good yet. I wish they were, but there's sometimes things that you can send for claims and get paid, and you really should have never gotten paid because there's things that aren't cross-checking. It's getting better. They're adding more cross-checks for sure, but sometimes you can bill for things that you're not supposed to. So we need to, as part of our requirement, we are supposed to know all the rules, follow all the rules, bill appropriately. Otherwise, that could end up in a fraudulent situation, and you do not want to end up under a review. Want to run your software reports regularly to ensure that your assessments and your HIPS code. So your HIPS code is when you complete your MDS, at the end of the MDS, that's going to be the code CAFE1, whatever it might be. That is going to indicate what you have for a score for your PT and OT components, speech, nursing, non-therapy, ancillary. I could drone on for days about how to calculate PDPM. That is not why we're here, but that's what we're talking about, that HIPS code that is calculated off of that MDS. And making sure that that carried over appropriately. Just because the computer is connected does not mean that it's accurate. Oops, we did something, there was an IPA in there, we never finished the IPA, but it's going to impact this billing period. We need to make sure that that gets in there. So you really have to have a good understanding of those requirements, and a lot of times that's going to fall in the lap of the nurse assessment coordinator. Triple check meetings should be held at least monthly. Determination of skill on admission. If there is no skill need present upon medical review, the payment may be taken back. So you could bill for Medicare and then you get under a review and Medicare says, nope, we're not going to pay for that. I have a question. Yes?
Talk a little bit about presumption of care and
I could, but that would take up the entire rest of our day.
There's some people that are unfortunate with the review process or are skittish to accept a patient that isn't,
Yeah, so the skilled care and administrative presumption of coverage, literally I could talk about that for a very long time. But what your best friend is going to be, if you have anything to do with anything Medicare coverage, accepting people, continuing to skill, you want Chapter 8 of the Medicare Benefit Policy Manual, cms.gov, do a search for internet-only manuals, and you will find it in there. That is your go-to guide. It's not that long of a read. There's a lot of great information in there. But yeah, I agree with you 100%, especially if you've got new folks who've only been working since COVID and don't necessarily understand what skilling is or administrative presumption is. Unfortunately, there are some entities out there that don't, like reviewing entities that don't know what administrative presumption of coverage is either. But it is outlined in there. So basically what that's saying is on the 5-day assessment, if they meet certain criteria and get into a certain case mix group in one of the 5 case mix components, that they are presumed to be skilled under Medicare, and the government has to pay us through the assessment reference date of the 5-day assessment, as long as what you coded on the MDS to get you into that category was appropriate. So that's, in a nutshell, really quickly what that is. But I think people don't know what that is. So yeah, absolutely. We could talk about that. And she was not a plant. I swear she was not a plant. It's going to be a lost opportunity if you do not use this. So generally, I am of the thought, if they meet the technical requirements, that doesn't necessarily mean they meet the clinical requirements unless they meet this administrative presumption. So if your facility has never heard of it, think that I'm making it up, Chapter 8 of the Medicare Benefit Policy Manual is going to be your place to go to find more information about that. And that's going to be a potential lost opportunity of not covering someone potentially through day 8, depending on what your assessment reference date is, when they would not be covered otherwise. Primary diagnosis. So part of the alphabet soup after my name, CRC, a lot of folks in our industry think, oh, clinical reimbursement coordinator. That's not what my CRC is. It's actually a certified risk coder. I'm a certified ICD-10 coder. So I could, again, because I have a sick, weird passion about ICD-10 coding, I could go on and on and on and on about that. But if we don't have a primary diagnosis in place that maps to a clinical category, and without turning this into a PDPM course, in the PT and OT components, that is basically driven from their primary diagnosis coded at I0020B on the MDS. And that is going to, there's a map. If you go to cms.gov, PDPM webpage, very bottom of the page, there are going to be several Excel spreadsheets that are the PDPM mapping tool. And it takes every single ICD-10 code there is. This is an insanely large file. And it will tell you whether this maps into a clinical category such as medical management, acute neurologic, other orthopedic, and whatever it is, or it will say return to provider. Return to provider means you're not going to calculate a score. You're not going to get paid by Medicare because your primary diagnosis doesn't meet a level of skilled care based on the bevy of experts who have created this Excel spreadsheet. They're not always right. We sometimes have to tell them, no, we need to add this one too, and then eventually they will. But we have to go by whatever that is for the fiscal year that we're in. So if we have somebody admitted with muscle weakness or repetitive falls or something of the like, or adult failure to thrive, those diagnoses are returned to provider. So basically the government is saying, there's not enough in that diagnosis based on our investigations of this diagnosis that's going to provide that needs skilled services on a daily basis. So you need to dig a little deeper. And if you're not digging a little deeper, or if you do dig a little deeper and that's really why they're here, adult failure to thrive, we have no other reason why they have adult failure to thrive, they just do, Medicare's not going to pay for that. So Medicare is basically going to say, well, we don't think they meet a skilled level of care criteria, so we're not going to calculate a payment score. If you don't calculate a payment score, you can't finish the MDS, you'll get a warning or an error that says you can't finish this because this is a return to provider. And now we have a whole problem. And, oh, well, I need to make up a diagnosis that's going to get me paid. No, there's no making up. If they truly have a diagnosis, and that is their primary diagnosis as to why they're coming into your facility, you probably should have never skilled them in the first place. So that goes to the understanding what skilled level of care is and what does that constitute, which Chapter 8 of the Medicare benefit policy will tell you about. So if we have this return to provider diagnosis, there's nothing we can do. We're going to end up being provider liable because we never gave a notice on admission to say, hey, you really don't meet skilled coverage criteria. There's nothing we can do about it. So now we have provider liable, or we have fraud, because either we're billing appropriately with the appropriate diagnosis, or we're making up a diagnosis just so we can get paid. Either way, it's not good. We don't want to do those things. And this needs to be a team effort. When we're looking at that primary diagnosis, it's not just going to be the nurse assessment coordinator. It needs to be whoever else is providing skilled services, PT, OT, speech. What are we working on? What is the skilled care being provided? What is the main reason why they're receiving skilled care? So that's a whole important piece that if it's not being managed appropriately, A, we could get no payment, or B, we could get incorrect payment. Because if we put in, nursing is working on one thing and PT is working on another, and it's equally skill worthy, and we choose the wrong code, we might not be getting enough money for the services that we're actually providing. So it needs to be a team effort, but a team effort of folks who understand what the requirements are, and that's the tricky piece. So we could assign these tasks to alternate staff, such as admissions, nurse unit manager, admitting nurse, other leadership roles to determine are they skilled on admission, but that means that whoever's doing that needs to understand what skilling is and what is constituting a direct skilled nursing service, an indirect skilled nursing service. Do we understand what management of plan of care or observation and assessment or teaching and training is, those indirect skilled services? And if we don't, we could be losing out. So again, these newbies that came in during the pandemic and have no idea what the Medicare rules are, because we could just admit everyone willy-nilly under the disaster related code, we're now kind of in a world of hurt. And that was another thing that CMS always said, well, you always should have been skilling them, That was the technical requirement, not the clinical requirement. The clinical requirement for skilled coverage never went away with the COVID pandemic public health emergency waivers, but a lot of people took advantage of it. We need to make sure that everyone is cross-trained who has to have any idea of what's going on with Medicare coverage. Again, Chapter 8, Medicare Benefit Policy Manual, Section 30.1 is going to be your go-to as to what is skilled services in the SNF. And ensure that your staff are knowledgeable on ICD-10 coding rules and PDPM clinical categories. So October 1st, we're going to see not only MDS changes, but some updates to the codes for ICD-10. The biggest one that I think will impact us is the Parkinson's code. So G20 is no longer going to be the code for Parkinson's disease as of October 1st. If you have folks that's their primary reason for coming into your facility, if you have that coded on your MDS, you're not going to get paid because it's not going to be a valid code anymore as of October 1st. So there's just so many fingers involved of what we need to do and how we need to cross-train. As I mentioned, the Beneficiary Notice Initiative, we need to administer a mandatory SNF ABN when admitting to the SNF with no skilled needs. There's very specific technical requirements associated with that. And under medical review, failure to administer that notice is going to result in provider liability, potentially all the way through the 100th day of coverage, or whenever they discharge from your facility, because they had no way of knowing that Medicare was not going to cover them. This is something we are required to do and know. Who is doing that in your facility? Does anybody know they're supposed to be doing that in your facility? Oh, we just give the notice of Medicare non-coverage, that expedited determination. That's not enough. There are 2 notices that are required. So there's just a lot of things going on. This could be something that could be assigned to admissions, but admissions, they would have to know that they didn't meet that clinical criteria. That means somebody would have to have that knowledge. Could be social services, billing office after determination of that notice is required. So maybe clinically we make that determination when we say, okay, Susie, social worker, can you please administer this? And then there's very specific requirements for administering it as well. There's some things we can't say, some things we can't do, some things we can't write on the form, we can't sign things for them, we can't check things for them. So there's very specific criteria. It's not just a matter of, hey, have them go sign this form. There needs to be some understanding of the Medicare requirements as well. And then making sure your staff are cross-trained on those instructions. So you can find those instructions, cms.gov, do a search for BNI, and it will give you a beautiful grid of all of the notices that are out there and the links to those different sets of instructions. And of course, there's different sets of instructions for different items. They don't make it easy, but they're trying. The stuff is there. All right, so that was pre-admission. Whew, good gravy. Now let's talk about the ICD-10 CM assignment, the completion of the MDS, all the things that we have to do while the resident is in the facility. And boy, I've talked way too long about pre-admission. We need to make sure that we have the correct information about the ICD-10 code. So just like we talked about, the rules need to be followed. The rules are updated every year. We need to make sure that those diagnoses are accurate because it can impact your care planning, your payment, your quality measures. Missed or untimely diagnoses are going to lead to inaccurate assessments. If you don't have the right diagnosis, you're not going to provide the right plan of care, which may lead to survey citations. All of the 5 case mix adjusted PDPM components are impacted by inaccurate payment with inaccurate diagnosis. And the diagnosis could include or exclude somebody from a quality measure. Anybody familiar with the schizophrenia stuff going on? Anyone? Oh, okay, yeah. So that's one of the things, which is why that kind of stemmed up is schizophrenia is an exclusionary factor for the antipsychotic. And a little too many people were having schizophrenia when they really didn't. So we need to make sure that we are accurately doing the ICD-10 process. We need to make sure that any staff who is responsible is cross-trained in ICD-10 coding. There's a lot of different rules. Coding conventions, chapter-specific guidelines, regular guidelines, proper use of the manual. You can't just say, hey Siri, what's the code for a fracture hip? You have to know all of the rules and be able to follow them because there's very, very specific diagnoses and rules that must be followed. Cheat sheets and internet searches, terrible, terrible, terrible. You need to make sure you're keeping your ICD-10 manuals up to date. It's updating for October 1st. They should be out now. They're definitely out on CMS and cdc.gov, the free PDFs. They're not user-friendly, but you should be getting new manuals every year. Oh, well, I've got one from 2015. That is not going to cut it. That is not going to work. Query the physician or physician extenders to obtain supporting documentation. Ultimately, it is the physician or physician extender's job to diagnose the resident. They have to have enough information in the medical record to make sure that we are coding the most specific diagnosis code. We cannot make stuff up. We can't say, oh, they have an antidepressant, they must have depression, and we can add that code. No, it has to come from the physician. In most settings, it's going to be a non-clinician assigning the ICD-10 codes. In our setting, it's usually a nurse, usually the nurse assessment coordinator. And we tend to put our clinical spin on it and say, oh, well, I know that COPD doesn't go away, but the doctor just has it written in past medical history, so I'm just going to put that in. You can't. If the doc doesn't indicate that it's currently happening, you can't put the ICD-10 code in your medical record. These are like the tips and tricks of ICD-10 coding, and if you don't have that knowledge, then you're going to have inaccurate information in your medical record. So we have a lot of F tags that are going to impact if our MDS schedule is not completed appropriately while they're in our facility. So I'm not going to go over each one of these, but these are all of the different tags that are impacted. So what do? How do we manage this? As I mentioned before, I'm not going to belabor this point, the ARD must be set on an MDS form or in the MDS software timely. If it's not done timely, it's not done. We can't go back in time and fix it because we want to look compliant or because we don't want to get in trouble by our boss. There is no backdating. There is absolutely no backdating. The only place that you can backdate on the MDS is Z400, where you are signing for the date that you collected the information for what you coded on the MDS. That's it. So if I did my interview for the BIMS 3 days ago, and I'm entering it today, I can put the date 3 days ago that I actually collected the information for the BIMS. That's the only section in the MDS. You can't backdate your assessment reference date, with the exception of if you're in your observation period with like day 1 to 8 of your 5-day assessment. But you can't backdate completion because, oops, this is day 15 and it's due on day 14 and I don't want to get an error, I don't want to get a ding, I don't want to get a something. You have to do it based on what the rules are. So I won't belabor that. But we want to make sure that we're cross-training our staff. While you guys are here, who's setting your ARDs in your facility? Because that's really the piece. As I mentioned, it's not who's completing your assessments, it's who's setting your ARDs that's going to be the financial impact. Revamp your OBRA MDS schedule to utilize federal limits. Don't be so rigid that if today is our ARD, everybody on the team has to finish it tomorrow. Give a little time. There's 14 days to complete an assessment from the assessment reference date. Do we want to give them all full 14 days? No. But we also don't want to cut ourselves off. Build in oversight for the MDS schedule, for the NAC, or utilize the regional supports if you have any. Who's overseeing? Is anybody auditing your assessments? Is there any inter-rater reliability going on in your facilities, or is it just one person in your building who knows how to complete the MDS and you're auditing yourself? You can't really audit yourself. Review assessment due reports in your electronic health record to make sure that you're not missing any assessments, and value the importance of the discharge assessment and tracking records. That's going to have a huge impact on how your quality measures are calculated, and how your census is calculated for staffing, for the 5-star staffing measure. If you don't have a discharge assessment in place, your census may look much higher than what your census is. So your staffing rating is going to look much poorer because you're not staffing for the 85 beds that it looks like you have when you really only have 60, because there's MDSs that are late for discharge assessments. And the missing assessment report in I-Keys, utilize that. We don't want it to get to that point where the government already knows that you're missing assessments, but that is another point that you can look to see if you are missing assessments. Transmitting the MDS, so per F640, the facility must transmit the MDSs into the national database via the I-Keys system. And if we do not do this, we're not going to have a calculation of PDPM, so we're going to miss payment. We're going to have citations because we weren't timely, and we're going to have inaccurate QM and 5-star calculation. So again, cross-train ancillary staff to transmit assessments. Does it take an RN to submit an assessment? No. It could be done by ancillary staff. You could have a third party. Maybe your software does it. Maybe you have a scrubber that does it for you. Utilize those automated transmissions if you have them through your electronic health record. If we do not have an accurate assessment, that is also going to impact us from a survey standpoint. If they're not completed accurately, it's going to first and foremost lead to an inaccurate care plan. If you have not assessed that you have a stage 4 pressure injury on your resident, you're not necessarily going to have a care plan based on you're missing that on the assessment. So we need to make sure that that information is accurate. Certainly it's going to impact payment, quality measures if we don't have an accurate assessment. Underpayment, overpayment, medical reviews. And this is just a quick example of what would happen if we have an inaccurate assessment. We don't need to go over it in depth, but there could be a difference just because you have an inaccurate assessment of, in this case, $27 a day for a 30-day claim period, $821 because you didn't code the MDS correctly. So we want to make sure that we are accurately assessing for all of these reasons. And I hate to put the money on it, but that's kind of like the title of this. That's what we're focusing on. Certainly care and quality is first and foremost what we should be focusing on. But how are we going to provide the care and quality if we're not getting paid at the rate that we're supposed to be getting paid? We already don't get paid enough. So if assessments are not completed accurately, inaccurate monitoring of the quality of care using the MDS quality measures, the 5-star, the SNF quality reporting program, inaccurate representation on the publicly reported Care Compare website. So we have another situation if we don't understand the rules of Medicare for coding a UTI. There are 2 specific criteria that have to be met. They have to meet evidence-based criteria. There has to be a documented physician diagnosis of UTI within 30 days of the ARD. This is one that I find is overcoded. So we may have the diagnosis of UTI, but maybe they didn't meet the McGear's criteria. So now we shouldn't be coding it on the MDS, but there's a diagnosis from the physician, so I'm going to code it on the MDS. If you have somebody who doesn't understand the 2 criteria that are required, maybe you have somebody filling in doing MDSs, now you're going to trigger for more UTIs than you actually need to trigger for because it didn't meet all of the criteria. So it's very important to understand all of those rules. It's a domino effect. If we don't do it correct on the MDS, it's just going to snowball. Resident acuity may not be calculated correctly, so this again may impact that staffing rating on your 5-star rating system. So not only are we looking at the census because we didn't finish those discharge MDSs, but if we just pushed out those MDSs because we had a lot of quantity that needed to be done for whatever reason, now our acuity may not look as high, and then our staffing rating is going to reflect, well, you don't need all of this staff. We are not going to have the right staffing acuity to calculate your correct staffing rating. That's partially adjusted by that, and then again, inaccurate representation on Care Compare. So 5-star nursing staffing levels are based on that case mix adjusted by RUG, soon to be PDPM. If the assessments did not accurately reflect the true acuity, you're not going to have the correct calculation. So even though it's not impacting something quality clinically, it's also impacting other parts of that 5-star program with the staffing ratings. If an individual who willfully and knowingly certifies material as false statement in a resident assessment is subject to a civil money penalty of not more than $1,000 for each assessment, or somebody who encourages someone to be false on the MDS could incur a penalty of not more than $5,000. So in section Z400, where we have to sign off an attestation for accuracy of completion of the MDS, there's a little in tiny print attestation as you're signing it that's basically saying, I swear I'm telling the truth, the whole truth, and nothing but the truth, and if I haven't been, I could be personally held liable, or somebody else or the facility may be held liable. So we want accurate assessments. If you're signing your name to that assessment, then I hope you are the one who did that assessment. This is why I don't sign for therapy minutes. I don't sign for something somebody else did, because I don't know that it's accurate unless I've confirmed that that information is accurate. So if somebody tells you, I need you to code schizophrenia on the MDS because we're triggering too high, no, they're on to us on that one. That's not appropriate. Absolutely not appropriate. Nobody should be telling you how to code something on the MDS that doesn't meet the coding criteria in the RAI User's Manual. If somebody is asking you to do that, I need you to show me in the RAI User's Manual where it is appropriate for me to do what you are asking me to do, because that is absolutely not appropriate. And here's that attestation. So I further understand payment of such federal funds and continued participation, I may be held liable. And just a quick example, somebody's telling you to code something because it's going to bump up our money. No, we don't do that. So we need to make sure full RAI User's Manual instructions are followed when completing the MDS. You don't, I had an administrator say, can't I just do some of this because we're behind? You have to read the instructions as you go and make sure that you're following them. So we need to make sure that we're following the instructions. That's why they're there. we have to follow these rules. These are the regulations, these are the instructions, these are the coding tips, this is the information. And if we're following that, then we're doing all right. It's going to trigger the care area triggers. It's going to trigger the care area assessments, which will lead to the care plan. But this is just a siloed piece. When it comes to any care planning or documentation, it's not just what comes from the MDS. We have to look at the resident holistically as well. Maybe utilize alternative methods of MDS completion. Maybe incorporate MDS completion into your nursing or interdisciplinary team assessments. Optimize facility software to incorporate REI language and definitions, and make sure whoever's filling those out understands those definitions. Because if you have a different definition of one thing than the nurses do, then it's not going to jive right into the MDS. I think every nurse should be cross-trained in MDS terminology. It's how many times have I trained nurses from being a charge nurse to an MDS coordinator who are like, oh, so that's why we're supposed to be doing it that way. I never knew that. Well, maybe if we train them, then their documentation would support what we need to do. So administrators and DNSs, maybe we need to look at having that cross-training, because if there's some cross-training there and we have that as part, it's going to be a little easier maybe to fit someone else into that role to cover a vacation or a pandemic or whatever. Maybe have a pool of per diem nurses. If you have a corporate structure, do you have sister facilities? Could you create some sort of a per diem pool to cover things? Maybe a corporate float nurse assessment coordinator. I've seen that in some entities. Travel MDS assignments, you're starting to see some of those. Maybe build in some oversight time for the NAC, or utilize regional or corporate supports for oversight. Somebody needs to make sure that whoever's doing the MDS is doing it appropriately. Maybe invest in a strong scrubber software. There are third-party scrubbers out there where you will submit the MDS and it will do a review, which is a little more in-depth than just the standard EHR review, and will help you drill down. Well, gee, you have this coded in this section, but something contradictory in that section, maybe you want to check and make sure. And that's actually how I became a better MDS coordinator, because I used a scrubber way back in the 90s, because I was new and I didn't know what the heck I was doing, and I didn't have a lot of oversight. I was the only person in the building, and I wasn't sure. Well, gee, you coded this behavior, but you didn't code that behavior. Are you sure? Yeah, I'm sure, because I know what the rules are, and that's fine, so I can put that away. Or, whoops, I made a mistake. Participate in resident conferences. If the NAC is not attending care planning or discharge planning meetings, there's potential for important information being missed or not carried over. So that could lead to inaccurate assessments in care planning. So if you're not participating, make sure that there's some way of communicating with who is participating. If there's something important that needs to be included, document. You can have a meeting, and if you don't document about it, what the heck's good is having the meeting if you're not going to utilize that? All staff should maintain updates to the care plan. It is not just the nurse assessment coordinator's responsibility to update the care plan. Now, certainly, your facility setup may be different, but federally, it doesn't say that the MDS coordinator has to update all the care plans. Meetings should be well documented so we can have that shared information, and it should be timely in the medical record. And prioritize your tasks. So this is a tool that we have at AAPACN, kind of a crisis mode, put it together with Carol Mayer, who is another one of our volunteer experts, on what to do if in a crash situation where the MDS coordinator has, flown the coop or has COVID or has a vacation. This is more so of a crisis mode. What do we need to do? What do we need to make sure? We need to open the assessments. We need to code section GG in a timely manner. We have to, maybe assign information to other people if they were doing the BIMs. So can somebody else do the BIMs? Can somebody else do the resident interviews, the preferences interviews, the pain interviews? Can we complete the assessments? Do we know how to do that? Making sure that there's transmission is done, all of those things. So just kind of like a bullet point. Here are the things you have to get done. Now, honestly, everything I've been talking about thus far, we have to get done. So we need to make sure that we are prioritizing the tasks and understanding what it is our coordinators are doing. Also, we have to look at Medicare case management. The whole piece associated with Medicare case management could be huge. That could be a whole job in and of itself. And if somebody's not managing that, that's where you're really going to lose some money. Not setting that ARD timely, as we talked about, not choosing the correct assessment reference date. So the assessment reference date is going to determine which period of time this assessment is going to gather information. So if your ARD is too early and they went on IVs after that, you could be missing out on an opportunity. Or if they had IVs in the hospital and your ARD is not set early enough to capture that, you could be missing out on an opportunity. So understanding what those different observation periods are, what it means to set the assessment reference date, looking at the resources used, and not just everybody's going to be day 8 for a 5-day assessment. We're not doing interim payment assessments, and this is how we do it. We can't be that rigid because you're going to be losing out. So not capturing those cognitive impairments, not capturing the diagnosis codes timely, not capturing those IV fluids, as I mentioned. All clinical staff should be aware of basic Medicare requirements. I know I'm living in a dream world here, but in a perfect world, everybody would know all of these rules. So we want to cross-train. Who's going to set that ARD? Is it going to be something that our software can automatically do for us? Can we have, that ARD page from the MDS and the admission packet, and the nurse, when they're part of their admission, is to just set a day 8 ARD? Because as long as you have the ARD set, if they discharge before that point, you can adjust your assessment reference date to the date of discharge. But if we don't have an ARD set, they come in on Friday night, nobody has set an assessment reference date for that 5-day assessment, and they discharge on Sunday, and the MDS coordinator comes in on Monday, there's nothing we can do. If we had an ARD set on the day of admission, then we can do our 5-day with our date of discharge as our assessment reference date. Technically, you're not supposed to do it otherwise. And incorporate the PDPM clinical requirements into assessment forms. Build it into the nurse's daily stuff so it starts to become second nature. If it's second nature, they're not learning anything new. It's just part of their daily nursing routine. We want to make sure that the direct care staff is participating in that review of daily skilled needs. It shouldn't just be one person making that determination. It needs to be a team effort based on the requirements. And although the interim payment assessment is not mandatory, so this is that optional assessment where you're going to change your payment, additional revenue may be missed due to lack of specialized review with those PDPM components in mind. So we want to maybe do that cross-training with our staff to say, hey, if they go on IV fluids, make sure you let me know, because we need to do something. Or maybe we need to be doing something where we're reviewing those skilled notes on a daily basis, or some sort of a chart check, something where we're not missing out. And this is just another example of a situation where we missed out on an opportunity with an IPA, and for time's sake, I'm running out. This could be a difference of quite a bit of money. So in that scenario, if you look at it more deeply, it shows there's a difference of $175 a day and change, which would be over $5,000 for a 30-day period, just because we didn't do an IPA when we could have. So we should all be aware of what the basic Medicare and PDPM requirements are, utilize chart checks to ensure that the daily documentation requirement is met, utilize that PDPM clinical criteria and nursing assessments, and cross-train those staff members. And then the physician certification, I'm droning on here. There's tons of requirements under Medicare. This is another technical requirement, physician certification. That process needs to be pristine. And if it's not done appropriately under medical review, they're not even going to look at the medical record. They're going to say there's no cert, denied, provider liable, give us your money back. So for Part A services to be payable, this certification has to be in place. This should be part of your triple check process. We're not supposed to bill unless we have a certification in place, following all of the requirements that are listed in regulation. This is a task that certainly could be assigned to ancillary staff for completion, providing there's an appropriate understanding of what that whole process is. It needs to be tracked for timeliness of completing that and when the next signature is due. It's not due on day 14, day 44, and day 74. There are certain requirements by day 14 and then every 30 days thereafter, on admission or as soon thereafter as is practicable is the first one. And you'll want to check with your Medicare administrative contractors to make sure that there are no other requirements. And then just making sure that you have a good understanding, and I know I'm running out of time. We have a missed assessment, we're provider liable. We have an inaccurate assessment, we're not getting paid appropriately. So you could have your business office or admission staff cross-trained to check for these things. An interrupted stay is huge. Do we understand what the interrupted stay is? If they go out and come back within 3 days, we're going to continue on from where they left off on their previous 5-day. If we don't have a good understanding of this process, we are not going to be billing Medicare appropriately. We may be billing for care we shouldn't have been billing for, or not doing an assessment that we should have been doing, and now we're going to be provider liable for missing an assessment. Again, the BNI process, that follows during their stay. If they're coming off of Medicare and we're not doing that appropriately, that's going to be a problem. We need to make sure that we are aware of all of these clinical criteria. There's so many things that the nurse assessment coordinator is responsible for in many of the buildings, including education. So, making sure that we have that education about all of these changes. If we don't have the education for our team, then we're going to be working off of inaccurate assessment. So all staff should be involved with those item sets. We're actually up to version 4 of the item sets now because they keep tweaking things, but it is on that same web page. And look at that item set. We are still on the draft, waiting for that final to drop at some point this month. But you guys have a very unique, highly specialized role in the SNF setting, and it's important that everyone's aware. It combines clinical, financial, regulatory compliance information, and because it's so specialized, clinical leadership needs to be aware of the risks of utilizing the NAC to cover open positions in the facility, or not allowing vacations, things like that. And while temporarily shifting the NAC to cover an open slot may solve an immediate problem, it's going to negatively impact you down the road with your quality survey outcomes, reimbursement, and 5-star rating. Oh, I have 1 minute for questions. But if there are any questions that come up, please absolutely email me. I love answering questions, and am still answering questions for people that I worked with like 25 years ago. So,
Any questions? I do have one, Jennifer. There are a lot of administrators in the room, and we all do know that, MDS is also related to, the care of our residents, but also on the opposite side is reimbursement. So if we do not have a PPS assessment completed timely, is there a financial penalty associated with that?
Great question. So it's not the completion from Medicare, federal Medicare. It's not when you complete the assessment, it's when the ARD is set. So if your ARD is set timely by day 8 of that Medicare stay, you can complete it a month later. You're not going to be compliant, but you're not going to lose money. You complete it, you bill for it, the completion date has no impact. Now, managed care companies, they have a whole different rule, and that's going to be based on which managed care companies. But no, as far as physical completion of the MDS, if it's late, you're not going to get a financial penalty. It's the ARD selection. Okay, well, thank you very much. Yes? Okay.
So you were saying Parkinson's isn't going to be accepted anymore.
G20, the diagnosis is, but the code is changing as of October 1st. Oh, no. No. They've made a more specific code. It's broken down, so it's G20 point A, point B, point C, and you need to change those codes. So a G20 is not going to be accepted anymore. Okay. Parkinson's is still accepted. It's just a different ICD-10 code.
Gotcha.
Yes. Great question. Thank you very much.